drug called that substance abuse and very good afternoon to all our compatriots joining us from across Nigeria, those listening in from the northeast, the northwest, north central, southeast, and southwest of Nigeria. It's our pleasure to welcome everyone to this 163rd edition of NDLA's Open Forum on X Space this Friday, the 21st of November 2025. I am your host, Femi Babafemi. This week we will be taking on another topic, and we have well seated in the house already. Someone very versatile, someone very knowledgeable, someone very experienced, indeed a consultant psychiatrist and head of clinical services of Federal Neuropsychiatric Hospital, Buduegba in Kwara State. I'll hold back his name first, but then he will be leading the conversation today on pharmacology of addiction and mental illness, how that those your favorite substances of abuse damage your brain. Once again, we'd like to appreciate all our compatriots joining us from across Nigeria, those joining us from other parts of Africa, Europe, America, Asia, and the Middle East. Like I said before, this is the 163rd edition of NDLA's Open Forum on X-Space, and I'm your host, Femi Babafemi. We're live from the national headquarters of this premier anti-narcotics agency, that's NDLA, National Drug Law Enforcement Agency, located in the nation's federal capital territory, Abuja here. We'd like to inform everyone at this moment that this is a platform where we share information, where we share knowledge, where we raise awareness about this problem of substance abuse and its devastating impact on human lives, public health, and indeed our environment is not spared. This platform also serves as a channel for us to provide help to those struggling with substance abuse, especially those who need treatment. It's equally a means for us to update you about all the activities of the agency, especially what we're doing to curb the scourge of substance abuse and illicit drug trafficking, as well as getting your feedback so that we can continue to improve on all that we do to serve you, our society, and indeed humanity better. It's also important that we let you know that this conversation is recorded, and apart from X Space here, it's also streamed live on our other social media handles, especially at NDLA 01 on Facebook and at NDLA TV on YouTube. You can always go back at the end of this program, that's right on the top of the hour, 5 p.m. local time, to listen to the recording and even share with others. That's a promise that we keep every week so that everyone can be a part of the benefits of the conversation we hold in here every Friday, 3 to 5 p.m. local time. Before I get to formally introduce our guest speaker for today to make his presentation, please let's remind you of some of the activities of the agency this past week, which we normally bring you in our news highlights segment, and that will be taken by Netta and Peace this afternoon. Let's have the updates, ladies. Thank you.
Thank you, sir. Good day to everyone, and thank you for joining us on this week's Exercise. My name is Natalie Dozier, and here are the NDLVA news highlights for the week. First, the headlines. Wanted drug baron arrested as NDLVA recovers large drug shipment, Forex in Lagos hideouts. Seizes over 14,440 kilograms skunk in Osun Forest, Lagos, Edo, Kwara, Taraba, Nasarawa raids. A wanted drug baron who operates under the cover of a businessman and hotelier, Frank Chijoke Ibemesi, alias Chiscobi, has been arrested by operatives of a Special Operations Unit of the National Drug Law Enforcement Agency, NDLEA, after weeks of intelligence and surveillance on his criminal activities. The 42-year-old Ibemesi, who is the MD CEO of Frank CJ Ibemesi Nigeria Limited, was arrested at his Daisy Garden Hotel, 6668 at Becker Street, Agro Palace Way, Isolo, Lagos, in the early hours of Saturday, 15th November 2025, after which he was taken into his warehouse at number 7 Pius Ezeobi Street off Agro Palace Way, Isolo, were 42 jumbo bags and 4 cartons of loud, a strain of cannabis weighing 1,762.8 kilograms, were recovered. Also seized from him as at the point of his arrest include 11,600 US dollars, 2,000 British pounds, 2,200 euros, and 50 Canadian dollars, all in cash. Attempts by a drug syndicate operating at Orita Apeje, Araromi Okeodo Forest Reserve, Ife South Local Government Area, Ocean State, to load and distribute across the country large quantities of processed skunk, a strain of cannabis weighing a total of 11,135 kilograms, were spotted on Tuesday, 11th November, by NDLEA operatives after days of surveillance in the forest. 2 trucks being used to transport the illicit consignments, a Volvo truck marked WWR 29XA and a Mercedes truck with registration number AWK 713YZ, were seized and 7 suspects arrested. Those in custody in connection with the seizure are Lucky Abiodun, Julius Amos, Victor Mbikili, Sunday Odoegu, Ibrahim Akani, Eze Godstime, and Fred Ifeanyichukwu. A total of 1,902.1 kilograms of skunk were recovered in parts of Edo State, while 184.1 kilograms was recovered along a bush path at Oza Ibanke Road, Ibanke, in Orio local government area on Thursday, 13th November. 672 kilograms was evacuated from Utese Forest, Ovia Northeast local government area on Friday, 14th November, with 494 kilograms recovered from a Mercedes-Benz car marked DE311BEN along Bingin Akure Road, where a suspect, Felix Eda, was arrested same day, just as Lucky Abaga was nabbed in another Mercedes-Benz car marked JJJ 56JW, conveying 552 kilograms. While 4 suspects, Michael Oko, Ofor Agada, Raphael Nkemjika, and Waboeze Franklin, were arrested with 68 kilograms skunk and 3.150 kilograms methamphetamine along Ijebu-Ode Expressway in Ogun State. Danjuma Tukura was nabbed with 172 kilograms skunk at Sumkani area of Ardokola local government area, Taraba State, on Friday, 14th November, and Wisdom Titus with 84 kilograms of same substance at Takum area of the state. In Adamawa State, NDLEA operatives on Friday, 14th November, recovered 396,000 capsules of tramadol from a suspect, Ahmed Isiaku Nda, at Aliyu Mustafa International Airport, Sibura, while 785 kilograms of skunk was evacuated from the warehouse of a drug dealer currently at large at Asob Maraba, Karu, Nasarawa State. 2 suspects, Jamiyu Kunle Cardoso and Oriyomi Waliyu, were on Friday, 14th November, arrested with 130 pouches of Canadian loud weighing 65.150 kilograms in Surulere area of Lagos, just as Taufik Moraina was nabbed same day with 282 blocks of Ghana loud with a gross weight of 141 kilograms at Oto, Oyinbo area of Lagos. In Kwara State, NDLEA operatives on Thursday, 13th November, intercepted a truck marked C0262KT along Ilorin Jeba Expressway, conveying 197 blocks of skunk weighing 78.565 kilograms and 155 cartons of rubber solutions. The truck driver, Umar Yakubu, was taken into custody. In another operation, a commercial bus with registration number KJA 657CY was intercepted at Ain Korin, Ilorin on Wednesday, 12th November, with 20 blocks of skunk concealed in a 50-liter jerry can recovered and the driver, Ibrahim Bello, arrested. While commending the officers and men of the Special Operations Units, Oshun, Lagos, Edo, Ogun, Taraba, Adamawa, Nasarawa, and Kwara commands for the arrest and seizures, Chairman, Chief Executive Officer of NDLEA, Brigadier General Mohammed Buba Marwa retired, and joined them and their colleagues across the country to continue with the ongoing balanced approach to the drug control efforts of the agency. That's it on arrests and seizures. Next is the updates on some of the other activities across the country for the week, brought to you by my colleague, Peace.
Thank you, Netta. My name is Peace, the pastor, and here are some of the wider activities across the country for the week. Nigeria's fight against substance abuse is entering a transformative era, driven by the National Drug Law Enforcement Agency's NDLEA Innovative Law Against Drug Abuse WADA initiative. What began as a basic awareness campaign has evolved into a comprehensive nationwide movement, uniting government agencies, civil society organizations, families, and citizens to address one of the country's most urgent social challenges. WADA emphasizes prevention, rehabilitation, and shared responsibility, reinforcing that the battle against drug abuse is a collective effort. By actively engaging persons in schools, markets, motor parks, and places of worship, the initiative converts awareness into decisive action, replacing fear with understanding and stigma with compassion. Its inclusive, community-centered approach motivates Nigerians to adopt healthier, drug-free lifestyles and to unite for a safer, more hopeful nation. Through this movement, the NDLA demonstrates that empathy, knowledge, and coordinated action can effectively combat addiction and uphold individual dignity. In this regard, on Monday, 10th November 2025, the Ogun State Commander of NDLEA delivered a WADA sensitization lecture to students and staff of Anglican Girls Grammar School, Obalende, Ijebu-Ode. The session informed participants about the dangers of substance abuse and its harmful effects on health, discipline, and academic focus. Officers encouraged students to uphold integrity, adopt healthy habits, and stay dedicated to their educational pursuits as a path to personal and societal progress. Similarly, the Kano State Strategic Command continued its preventive education initiative with a WADA sensitization lecture at Madrasa to Abdurrahman bin Ali Tafizil Quran Goron Duse Bayan Reka in Gwale local government area. The interactive session emphasized the moral, spiritual, and social consequences of drug abuse, urging learners to resist negative influences and maintain strong moral values rooted in discipline and self-control. On Tuesday, 11th November, the Katsina State Command of NDLEA conducted a WADA enlightenment lecture for students and staff of Great Achievers International School, Daura. Officers sensitized students on the harmful effects of substance abuse on mental and physical well-being and encouraged them to cultivate focus, determination, and accountability in their academic journey. Meanwhile, the Zone 9 Command paid a high-level visit to the Governor of Osun State, Senator Ademola Adeleke, as part of its wider advocacy effort. The visit underscored the agency's commitment to strengthening partnerships with state government in maintaining drug demand reduction efforts and promoting a drug-free society. Building on the day's advocacy effort, the Zamfara State Command delivered a WADA sensitization lecture to students and staff of Government Day Secondary School, Benurua, Gusau. The session highlighted the wide-ranging consequences of drug misuse and encouraged students to make responsible decisions that support their aspirations and safeguard their future. On Wednesday, 12th November, the Lagos State Strategic Command of NDLEA held a WADA enlightenment lecture for students and staff of Vandu Junior Secondary School, Surulere. The session informed learners about the social, health, and academic risks associated with substance abuse while promoting positive peer influence as a vital tool for building a drug-free society. Expanding its sensitization campaign, the Senate Special Area Command of the agency paid a WADA advocacy visit to the management of the Administrative Staff College of Nigeria, ASCON, in Badagry. The engagement focused on increasing institutional support for drug prevention initiatives and emphasizing the importance of collective responsibility in drug control efforts. The Niger State Command strengthened its youth-focused prevention efforts with a wider advocacy lecture at Zubairu Primary and Secondary School, Paiko. Participants learned about the dangers of drug abuse, and students were encouraged to adopt discipline and sound decision-making as foundations for lifelong success. Intensifying its advocacy efforts, the Oyo State Command further promoted the anti-drug message with a wider sensitization lecture at Adebisi Adibi Millennium Secondary School of Bomosho. The session highlighted the negative impact of drug misuse on academic performance and character development, urging students to stay focused on their goals. Additionally, the Ebonyi State Command delivered a wider sensitization lecture to students and staff of Holy Ghost Secondary School, Abakaliki. Officers informed learners about the psychological and social consequences of drug abuse and encouraged them to uphold discipline and moral integrity. On Thursday, 13th November, the Enugu State Command of NDLEA took the wider advocacy campaign to City Girls Secondary School, Enugu. The sensitization lecture stressed the importance of avoiding drug abuse, resisting peer pressure, and adopting a lifestyle centered on responsibility and academic excellence. Concluding the week's activities, the Jigawa State Command delivered a wider enlightenment lecture to students and staff of Government Science Technical School, Ringim. The session educated participants on the health and social hazards of drug misuse and urged students to remain committed to education, discipline, and positive behavior. That's the update for this week. My name is Peace, and I'm going to hand you over to our host, Mr. Femi Babafemi.
All right, thank you very much, dear Peace. Welcome back from the news alert segments. And let's remind ourselves about some of our rules guiding our engagement on this platform today. Please note that when we approve you to be on the speaker's corner, ensure you remain muted until after the presentation by our guest speaker, and then we start inviting individuals to unmute themselves one after the other to make their contributions or ask their questions. Let's keep to this so that we can enjoy the conversation, we can hear one another, and then we'll be able to seamlessly assimilate whatever we're discussing. That will always appreciate your cooperation every week. Quickly, let's tell you about the NDLA's call center. That's a platform that provides support to individuals who probably do not know how to access help, how to get help, especially those struggling with substance abuse, or those that out of the fear of being judged or being stigmatized, they are afraid or scared to walk into a treatment center to seek help. All you need to do is right from the comfort of your home, dial our toll-free helpline, which is 0800 10203040. The number to dial again is 0800 10203040. And then you have right at the other end of the call, we have counselors, clinical psychologists, psychotherapists, and psychiatric doctors to attend to you. They work 24/7. You can call the number anytime, any day, and you would be adequately taken care of. You would be treated appropriately without any fear of being judged or being stigmatized. That's the hallmark of the service of that platform. And another thing I would like to tell you about the NDLA call center is the fact that you are not paying for the call. That's why we call it toll-free helpline. You call, you dial it, the bill is on us, so you have nothing to be afraid of. And apart from that, it's the service is language sensitive, meaning that if you cannot speak English or Pidgin English, our experts there can attend to you in any of the three major Nigerian languages of Hausa, Yoruba, Igbo. This is to further deepen the extent, the reach of this service to those who are in the rural areas in the communities that may not be able to speak English or Pidgin English, but then if they can speak any of the three major Nigerian languages, they can still dial these numbers, seek help for themselves or for their loved ones or their friends. That's that about the NDLA's call center. Now let's formally introduce our guest speaker today, and is no other person than Dr. Dauda Suleiman. He is a consultant psychiatrist and head of clinical services, Federal Neuropsychiatric Hospital, Budo Egba in Kwara State. Indeed, Dr. Suleiman hails from Ilorin, the capital city of Kwara State, and obtained his MBBS degree from the University of Ilorin in the year 2000. He began his residency training in psychiatry at the Federal Neuropsychiatric Hospital, Enugu, in 2004, and later continued same at the University of Ilorin Teaching Hospital in 2006. He became a fellow of the National Postgraduate Medical College of Nigeria in 2010. In 2012, Dr. Suleiman was appointed consultant psychiatrist at the Abubakar Tafawa Balewa University Teaching Hospital, Output, Bauchi, where he served as head of the Department of Psychiatry for 9 years. In 2021, he joined the University of Ilorin Teaching Hospital as chief consultant psychiatrist in the Drug Abuse Treatment, Education and Rehabilitation Unit of the Department of Behavioral Sciences. He was later seconded to the newly established Federal Neuropsychiatric Hospital, Budueba, where he served as head of research and training in 2022. He is currently the head of clinical services at the same hospital. Dr. Suleiman is a master trainer in TreatNet and has organized numerous training programs on TreatNet at the primary care level. He is also a master trainer for the Mental Health Gap program in Nigeria. He participated in Drug Help Net as an emergency online support platform for drug users during the COVID-19 pandemic organized by UNODC Nigeria, and has completed the UTC Colombo training program. He is an active member of the Association of Psychiatrists in Nigeria, APN, and the Suicide Research and Prevention Initiative, SOPAN, where he served as the Northeast Coordinator. He also served as the Northeast Coordinator of the International Society of Substance Use Prevention and Treatment Professionals, that's ISOP Nigeria chapter, from 2018 to 2021. A distinguished researcher, Dr. Suleiman's scholarly work focuses on public health, mental health, substance use across various populations, and psychiatric comorbidities in patients with physical illnesses. He has published extensively in both local and international journals on drug use and related challenges. Please join me in welcoming Dr. Dauda Suleiman as I invite him to unmute himself now while we listen to him spend the next 20-30 minutes discuss our topic for today, that is pharmacology of addiction and mental illness, how favorite substances of abuse damage your brain. Please go ahead with your presentation, Dr. Suleiman. It's a pleasure to have you here.
Thank you very much, Mr. Femi. I'm honored and privileged to be with you this afternoon. And just like NDLA used to do every week, this is another very beautiful and timely topic, pharmacology of addiction and mental health, how favorite substance abuse damage our brain. So this afternoon I'll be talking about this topic and the reason why we need to talk about pharmacology of addiction. The topic, just as I said, is germane because our society is confronted with silent epidemics that is reshaping our community, evolving our health system, and claiming potentials of our countless youths. That is the problem of addiction. We should realize that we are not just here to talk about drug use, but we are here to explore the pharmacology of the drug use and how it affects this organ in our body, our brain, because the substance use affect almost all organs of the body, but the brain that defines our immunity also is equally affected by substance of abuse. Addiction should not be seen as matter of choice because people tend to be judgmental when we are talking about substance abuse. People that have substance use problem, people judge them and they believe that it's something that they can stop on their own. Some people consider them as being morally weak or they have moral failure. Some even consider substance use as demonic possession or suffering from family or generational cause. However, problem of substance abuse is far, far more than this, and it should be considered as a complex neurobiological disorder in which substance of abuse, such as alcohol, cannabis, opioid, stimulants, and even some of these common prescription drugs like tramadol and others, morphine, and so many others like that, subtly affects the chemistry and physiology of our brain. What are we saying? You know that these substances affect the ability of our brain to take important decisions because you know that there are one part of the brain that are essentially for decision taking. So somebody who is suffering from substance abuse may have problem taking decision, all these important decisions. Also, substance also rewire the brain functions. In other words, this substance will not just change our behavior, it changes brain structures and functioning. So therefore, it's very important for us to understand how these substances of abuse damage the brain and so as to know ways to prevent them, to know the effective way of preventing substance abuse and how to detect this problem early and how to manage them from evidence-based. And that's why pharmacology of the substance of abuse coming, because you are not just guessing. When you understand the science behind addiction, when you understand the psychology, pharmacology behind all these substance of abuse, and how it relates to mental illness, you are not guessing when you are treating them. You are using evidence-based method in the treatment. So that's why we need to know all these things. Pharmacology of addiction will also permit us to study the brain reward system and how addictive substances manipulate it for short-term pleasure and the cost of long-term harm. What am I trying to say here? That is, many of these addictive substances act on the reward system, the brain, the reward circuit of the brain, giving them this short-term pleasure effect. However, on the long run, it affects and damages the brain of this individual. It also highlights how mental illnesses and addiction often coexist together. Understanding this will make us to move from guesswork to precision, from stigma to science, and from reaction to prevention. So now let's talk about the epidemiology of substance abuse. We have different data from different organizations and agencies, but let me quote recent data from UNODC World Drug Report of 2025. The data stated that about 316 million people globally are using substance of abuse, and this excludes alcohol and tobacco. So what I'm saying, that is more than 300 million people are using substances of abuse, and this excludes alcohol and tobacco. So that means we have those who are using substance, tobacco and alcohol to these statistics. We are going to have very staggering and scary statistics. And the same study, the same release also say that about 6% of the world population between 15 to 64-year-old abuse substance. That is 6% of the world population aged between 15 years to 64 years. They abuse substances. And what are the common substances of abuse they are using? Cannabis has been found to be most commonly abused substance worldwide. And From the statistics, about 244 million users of cannabis have been reported globally. This was followed by opioid, as we find about 61 million users of opioid globally. Amphetamine was found to be used by more than 30 million people worldwide. This was followed by cocaine, ecstasy, and some other substances of abuse. Also, these are the statistics of people who are using substances. But what about those who are having problem as a result of these substances they are using? That is, those who have developed substance use disorders. Globally, about 64 million people suffer from substance use disorder as at 2024. 64 million people. However, the treatment is limited worldwide, and only about 1 in 11 people suffering from substance use disorder have access to treatment globally. Also, if you look at the mortality of substance use disorder, it's reported that about 600,000 people die annually from the direct effect of psychoactive substance use. Also, look at the other impact of substance use. We are talking about socio-economic impact of substance of abuse. Most of the unrest and security threats worldwide has been found to be associated with the use of substance globally. So now let's come back home. In Nigeria, what is the prevalence of substance use? From the same study by UNODC, the prevalence of substance use in Nigeria is among people aged between 15 to 64 years found to be 14.4. And if you look at the world global prevalence, that is 6%. So our own prevalence is even more than twice the global prevalence. So we know that there is a danger. That's why we call it, we have epidemics of substance use disorder in Nigeria. Then about 3 million people suffer from substance use disorder. And out of this, only few among them have access to effective treatment. Also, cannabis has been found to be most widely used illicit substance in Nigeria, just like global statistics show. However, use of opioid, especially tramadol, is now on the increase among Nigerian users of substance use. The another thing that we should look into is that people who are using injectable drugs, the prevalence of HIV among them to be as high as 6.2%, and as against the now that the trend of HIV is coming down. But among those who are using injectable substance, the risk is still very high among them. And just like I said, they have little access to evidence-based treatment. They have limited access to evidence-based treatment in Nigeria. Okay, so now let's go to the pharmacology of addiction. So talking about pharmacology of addiction, we're talking about scientific study of how addictive substances interact with the brain and body, and how this interaction leads to dependence, compulsive drug-seeking behavior, withdrawal, and long-term neurobiological changes. That is, we want to examine how the substance is being used and the effect this substance is having on the brain and body of the user. So, what are the routes of use of some of these substances? We want to consider them. Then, what are their effects on the brain? And then, which neurotransmitters and receptors do they affect in the brain? Then, how do they produce the pleasurable effect? How they cause craving in the individuals? And how do they lead to tolerance and withdrawal symptoms in people that are using them? So those are the things that we want to focus on this afternoon before we now go to the association with mental health problem Primarily, substances such as alcohol, opioids, nicotine, cannabis, benzodiazepine, stimulants, and other substances have different routes of use. Commonest method are by swallowing, by snorting, by smoking, by inhaling fumes, by intramuscular or other form of parenteral use, then topical use. So this rate of use will affect or the how effective those substances we have in the body. For example, somebody that is smoking will have the effect within a very short period of time. Within 7 to 10 seconds, you see the effect of smoking and psychoactive substances. Whereas if it's something that's swallowed or injected, it may take between 20 to 30 minutes before we see the effect. Similarly, if a drug is administered via intravenous injection, the effect is very rapid or instantaneously. However, somebody that is rubbing on the skin may take a longer time before we see the effect of those drugs. So that's about the route of use of psychoactive substances. Then, how do people get addicted to this substance? We should all know that if you don't take substance, there is zero possibility of you getting addicted to that substance. So for somebody who has never tasted a substance before, is not likely to get addicted to that particular substance. Even though it's not everybody that use a particular substance that get addicted to it, but those people who never use substance is not likely and they can never get addicted to the substance. So when people start using substance, they start with experimentation. They use it, just experiment with the substance. They want to see the effect on the body. But when they like the experience, the individual can graduate to occasional user. Then from occasional user, they can graduate to regular users before now getting to compulsive or addictive users. So now to the meat of the presentation. How does this psychoactive substance affect the brain? When substance of abuse get into the body, it has to find its way how to communicate with the brain. The brain normally is a communication center consisting of billions of neurons or nerve cells. Each neuron consists of cells body and nucleus and axon tip and many dendrites. So these are each neuron has this structure, and is this structure that they use to communicate with one another. And the neuron send messages from one neuron to another by use of chemicals known as neurotransmitters. There's this network of these neurons in the body from the central nervous system to the peripheral nervous system. If you're talking about the central nervous system, you're talking about the brain and the spinal cord and the peripheral nervous system. So this network of nerves coordinates among themselves and regulate everything, including what you feel, what you think, and what you do. These messages are passed through the chemical agent, just like I said, neurotransmitters from the one axon terminal across the space known as synapse or synaptic cleft to another axon. Neurotransmitters being released from these nerve cells have different functions. Some of them have excitation function, that is, they are stimulating in nature, while some of them have inhibitory functions. That is, they inhibit the activities of the brain. Example of excitatory neurotransmitter in the body is dopamine, while the example of inhibitory neurotransmitter in the body is GABA neurotransmitter. A neurotransmitter and its receptor operate like a key and lock. That is, for neurotransmitter to have effects, it will have to lock to the receptors in the other neuron. Each receptor will pass on to the appropriate message only after interacting with the correct kind of neurotransmitters. Once the dopamine is released, for example, from sensing cells, it crosses the synapse and make contact with receptors in the other neurons, and thereby passing the message to the other neuron. Then, after passing this message, the transporter locates it on the sending, a transporter located on the sending cells will cycle the dopamine. That is, there will be the uptake of the dopamine back into the sending cells. That's why we don't have accumulation of dopamine in the synaptics. There is this control there that the dopamine will be released. The other cell will sense that something has been released, and the receptor will pick the message. Then the transporter will bring back the dopamine back into the neurons and release the cell, the dopamine. So that's how they are communicated. However, psychoactive substances tap into this brain communication system, and they mimic and sometimes disrupt the way nerve cells normally send messages or receive messages. There are different ways in which they can do this. For instance, some substances can activate neurons because their chemical structure mimic that of natural neurotransmitters. This similarity in structure will fool the receptors and allows substances to lock into the receptors and activate the nerve cells. Meanwhile, the correct or the natural neurotransmitters will be blocked from communicating with these neurons. Although these substances mimic brain chemicals, they do not activate the nerve cells the same way a natural neurotransmitter will act. Thereby, they transmit abnormal messages through the network. Other psychoactive substances like amphetamine or cocaine can cause nerve cells to release abnormally large amount of natural neurotransmitters. That is, they are not going to mimic the neurotransmitter, but they will make the cell, these neuron cells, to release normal natural neurotransmitter like dopamine, but will now be released in abnormally large quantity. Also, they also now prevent the reuptake of this released dopamine back into the neurons, thereby disrupting the way the message is being passed normally. For example, cocaine exhibits its effect by also, for example, cocaine will exhibit its effect by preventing normal reuptake of dopamine from synaptic cleft. Thereby, you have excess dopamine in the synaptic cleft and this will now make the message to be excessive. Meanwhile, cocaine will have attached itself to the neurotransmitter, preventing neurotransmitter from doing their job of recycling the dopamine back into the sending cells. Hence, dopamine keep circulating and making contact with receptors, and thereby the excitation will continue like that and like that. Another way a substance can affect the neurotransmitter is by imitation. Substances like heroin mimic the natural neurotransmitters endorphin and enkephalin, which are responsible for producing pleasure response and blocking pain in the body. These natural substances send their messages the same way as all other neurotransmitters do, that is, by making contact with their receptor sites. These particular sites are called opioid receptors. Opioid receptors will now recognize heroin and other opioid as similar to enkephalin and the naturally occurring neurotransmitter, that is endorphin. So that will allow them to attach to the receptors. However, these substances produce a stronger effect than those produced by the natural neurotransmitters. Hence, there is no natural signal to stop their activation. So this now how the additional occur. The brain the way the brain communicates is the same everywhere throughout the brain. However, different parts of the brain are responsible for coordinating and performing specific function, and certain areas of the brain are more affected by substance use than others. The area of the brain most involved in substance effect and addiction are the brainstem, the central cerebral cortex, and limbic system. The brainstem controls functions critical to life, such as heart rate, breathing, and sleeping, while the cerebral cortex are responsible for processing information from our senses and thinking and judgment center of the brain. It has power and ability to think, to plan, to solve problems, and to make decisions. The limbic system, on the other hand, contains brain reward system. The limbic system links together a number of brain structures that control emotional memory and regulate the ability to feel pleasure. Feeling pleasure motivates us to repeat behavior that are critical to existence. So the limbic system activates when we perform these activities and also by substance abuse. What I'm saying with all these terminology I'm using is that the neurotransmitter has different effect on the brain, and it depends on the type of part of the brain that has been activated. But we have different part of the brain. However, there is this limbic system which is known as reward pathway, and anything that we do, if this limbic system is activated and the effect at the memory is pleasurable to us, the limbic system we appreciate and want the effect to be repeated. So, however, when substance of abuse attach or communicated with this center, you now see it as pleasurable effect, and you want to be repeating that effect, and that's why somebody who is using substance will keep on using the substance, because it's having that effect from the limbic system. The brain reward circuits in the limbic system is critical to the development of addiction. Our brain are wired to ensure that we repeat life-sustaining activities by associating those activities with pleasure or reward. This pleasure or reward is largely related to neurotransmitter dopamine. Certain survival activities like eating is associated with limbic system, and it stimulates production of dopamine. Also, all psychoactive substances of abuse also directly or indirectly target this reward system by producing excess dopamine in this reward system. However, substance abuse are much more powerful than the natural reward system. When some substances of abuse are taken, the release of dopamine can be as high as double or even multiple the normal dopamine that can be released by the natural neurotransmitter. And when smokers are, for example, when some substance of abuse are taken, they can release double. I've said that they can release double to multiple times the amount of dopamine that the natural reward system do release. In some cases, this occurs almost immediately. For example, if somebody just smoked a cigarette or injected any substance of abuse, the euphoric effect is immediate, and the pleasurable effect is so high that they prefer to be doing these particular activities than to be engaging other things that will give them reward that is not as high as this substance they are abusing. This overstimulation of the reward system produces euphoric effects sought by people who abuse substances and teaches them to repeat the behavior. I think I've explained that one before. Whenever this reward circuit is activated naturally, the brain notes that something important is happening that needs to be remembered and teaches us to do it again and again without thinking about it. And the same thing happens to people that are abusing substance. However, nature has put some things in in the brain that if the, like I've explained before, that if you have excess production of dopamine from natural occurring neurotransmitter or effect, there will be regulation of this. But when somebody is using substance of abuse, there will be loss of this regulation, and the brain will now want to compensate by reducing the receptors on which the dopamine reacts. So when these receptors are reduced, the substance will now want to generate more dopamine, and that's why those who are using substance will need to increase the dosage of the substance they are using, because they want to produce more dopamine so that they have the similar or even more effect than the one they are getting from those substances they are using before the brain try to regulate the amounts being released by the brain. Okay, so that is how the reward system lead to addiction. That instance, the substance is released by the system, dopamine is produced by the limbic system, and you get the euphoric effect or pleasurable effect. Brain want to control the amount of dopamine that's being released, and because of this, dopamine receptor is down-regulated. The individual want to increase the substance again, so that I want to produce more dopamine in the limbic system. So, and that will lead to what is known as tolerance, because you need higher quantity of the substance to achieve the same effect you are having before with low quantity. Now, let's briefly talk about the effect of some substances on the brain. As we talk generally on all of them. So now I want to talk about some specific substance and the neurotransmitters that they act on in the brain, briefly. For example, you have alcohol. Generally, alcohol belongs to the group of drugs known as depressants, and that means they have depressing effect on the brain activities. And alcohol normally they achieve this by acting on GABA receptors in the brain, leading to inhibition of L-methyl D-aspartate glutamate receptors. Ordinarily, NMDA receptor, they are excitatory receptor. But when alcohol acts on GABA receptor, it will reduce it will inhibit the firing of L-methyl D-aspartate glutamate receptor, thereby leading to depressant effects on the brain. Also, opioid has like opposite of this. Opioid is an agonist of main opioid receptor in the brain, and they inhibit the GABA receptor in the brain, thereby allowing the excessive release of dopamine in the brain, leading to more firing and increased activities of the brain increased activity of dopamine in the brain. Cocaine acts by blocking the reuptake of dopamine, while cannabis has special receptors in the brain known as they act tetrahydrocannabinol partial agonists in the brain. Thereby they alter the activity of the GABA transmission in the brain. Also, nicotine also has special receptors in the brain, and they act through those receptors in the brain. So these are the ways that these substance abuse affect physiology and pharmacology of the brain, leading to addiction, tolerance in these people. So how do they now cause mental illness? Because if you're talking about substance use and substance use related disorder and substance related disorder and substance use disorder, we are looking at whether the use of substance is creating mental illness in the individual or is just related to it. And we have different models that we can look into how they related. First one is to look at it from the angle of self-medication hypothesis. In this self-medication hypothesis, those who are using some substance will be suffering from underlying psychological or stress-related problem, and they are using substance to reduce this effect on them. It's like they are using to self-medicate themselves. For example, somebody who is having chronic pain may start using analgesic, and by using this, and they get addicted to the stuff. So that means the physical or psychological problem started first before the substance use problem begins. In other words, substance use is not primarily used for pleasure, but as a form of maladaptive coping strategies to relieve distress in the body. According to this model, individuals experience distress symptoms. They discover often accidentally that the substance temporarily relieves these symptoms in their body. They then begin to rely on that substance as a form of self-medication. Over time, repeated use of this substance will lead to tolerance, dependence, and possibly addiction among them. So that's what the model of self-medication is telling us about the relationship between substance abuse and psychiatry or psychological problem. The second model is substance-induced problem. In this model, the problem started with the use of psychoactive substance, and the mental illness will now come as a result of use of the substance. The model proposes that certain psychoactive substances, when used acutely or chronically, they directly cause psychiatric symptoms in the individual using them. These psychiatric presentations are not primarily mental disorder, rather they result from pharmacological effects of the substance on the brain. In other words, substance causes the psychiatric symptom. This model is central to understanding why mental health presentations often appear in the context of alcohol, cannabis, stimulant, opioid, or sedative abuse. Substance may induce psychiatric symptoms through neurochemical disruption. We talk about different ways that the brain send messages within themselves. So substance can disrupt this chemical pathway, leading to psychiatric symptoms. Also, sometimes the direct toxic effect of this substance can affect the brain. For instance, we have substances like inhalants, the snuff, glove, glue, and some of these inhalants have direct toxic effects on their brain, maybe affecting them really. Also, common psychiatric. Okay, let's look at the common psychiatric symptoms induced by substances. The first one is psychosis. Psychosis has been reported among people that are using cannabis, cocaine, and amphetamine. Also, people that are using alcohol, opioid, and sedative may present with depression. Cannabis has also been reported more among people with anxiety problem has been reported among people that use stimulants, caffeine, and those who are using cannabis too. Cocaine and amphetamine has been found to present with manic-like states and sometimes hyperactivity. Cognitive impairment has also been reported among people that use alcohol, inhalants, and solvents, while aggressive and impulsive behavior have been found among people that also use alcohol and stimulants. So, primarily, how do we distinguish whether the problem we're having is substance-induced problem or is primarily psychiatric illness? Firstly, we want to look at the temporal relationship of the substance users and the mental illness. If the symptoms start after using the substance, or when the patient is suffering from the effect of the withdrawal of the substance, more likely the result are the substance is the cause of the problem. Also, when the psychiatric symptom resolved after cessation of substance use, that means the problem may be as a result of substance the individual is using. If there is no prior psychiatric illness in the individual before using the substance, so also there is high chances that the substance used is the cause of the psychiatric presentation. Also, there are some substances that have been known to result to some psychiatric condition, like people that are using cannabis, high potency cannabis, and starting from early age has been found to lead to psychosis and even schizophrenia among the user. So all these things will tell you whether the problem you're having is from substance or is comorbidity of substance and mental illness. So that will now take us to the third model, where there is this comorbidity, that is, it's not the substance that's causing the mental illness, and it's not the mental illness that are being treated with the use of substance. But however, the two of them has similar or they share vulnerability model. So, and these vulnerability factors share might be genetic predisposition, because there's some genetic disorders found among individuals. If somebody may be predisposed to having mental illness, at the same time, they may have predisposition to developing or having substance use disorder. So that's one way. Then apart from genetic predisposition, developmental vulnerability is also there. That is early life experience. Some people that pass through stressful early life experience, this may predispose them to developing substance use disorder later in life, and also may also predispose them to developing psychiatric disorders later in life. Then also like abuse as a child, prenatal stress, or exposure to toxin may also be a vulnerability pathway to developing psychiatric disorders and also substance use disorder. Apart from genetics and the inter-issue, we can also have environmental factors as vulnerability factor for both development of psychiatric problem and substance use problem. These environment factors might be in form of social factor, family factor, or some other risk factors in the environment. If somebody is from a family that they discipline excessively, or they abuse the children in the family, this may lead to both problem of mental illness and substance use among them. Then somebody that grows in the environment with high stress may also lead to both psychiatric illness and substance use problem. Peer pressure, poverty, and violence in the environment also been found to be vulnerability factor for both mental health issues and substance use disorder. Also, family instability and parental substance use may also be factor that can be responsible for development of both psychiatric illness and substance use problem. So these factors increase stress, reduces, because all these environmental factors and family factors increase stress in the individual. Which treatments of substance use in the presentation, let me just talk briefly about treatment of substance use and mental health problem. We're talking about the biological components. That means we are talking about the drug treatment and other physical treatment. Psychological treatments, that means you are talking about we are considering the psychological intervention, while social treatment we involve the use of social factors and in the treatment of these disorders. So, and when talking about the management, that means you do biological investigation, we do psychological investigation, and we do social investigation. Also, we want to do biological therapy, we use social therapy, and we use psychological therapy. So, but I will limit myself to biological therapy or pharmacological treatment of substance use disorder here, because the topic is essentially on the pharmacological aspect of the treatment. So, firstly, you have to identify the substance the individual is taking. After identifying the substance, you want to know the level of use and other things that are related to it. You want to look at the motivation of the individuals, and you look at the state in which the individual comes in. Sometimes if you come in with overdose, you may need to reverse the overdose. It's always something like if they come with opioid overdose, you may need to use opioid antagonist to reverse the overdose. We have things like nitrazone and naloxone. Those is not readily available in the country, but those are the ones that you can use to reverse the overdose in them. Then people that are using opioid, essentially the primary method that has been encouraged is to stop the use of the substance, maybe by going through the doing the detoxification, then you want to practice total abstinence. But however, sometimes if total abstinence is not possible, you want to consider the harm reduction aspect. That's when medication assisted therapy can come in. Substances like methadone has been found to be very useful in this regard, where you replace use of harmful opioid with methadone under strict therapist prescription. Also, people that are using nicotine, you can use nicotine replacement therapy for them. There are different ones. Some of them are agonists, some of them are partial agonists. Also, you can use substances that reduce craving in people that already have problem or addiction in them. So we talk about things like gabapentin, buprenorphine for those who are addicted to alcohol. Also, so there are some other substances that can be used, but they are still at experimental stages. People have been talking about the immunotherapies, monoclonal antibodies for drug abuse, and other glutamatergic agents in the treatment of some of these substance abuse. However, but essentially, if you want to manage people's substance use disorder, it's not majorly the medical treatment. You have to combine both psychological, social, and biological treatments in their treatment. So not just the physical or pharmacology treatment alone. So, in conclusion, the pharmacology of substance abuse and mental illness reveal a complex interplay between psychoactive drugs and the brain neurobiological system. Substances such as alcohol, opioid, cannabis, stimulant, and sedative normally hijack the normal neurotransmitter activities and pathway of the brain, particularly the dopamine, GABA, and glutamate pathway, to produce short-term euphoric effect. And while producing this short-term euphoric effect, they are causing long-term neuroadaptation that will impair cognition, emotional regulation, and decision-making of the affected individual. Repeated exposure lead to disrupt the circulatory system, and this may eventually lead to development of psychiatric symptoms and psychiatric disorder in them. Ultimately, what we are preaching this out is that the several substances people turn to for pleasure or relief can progressively damage neural network, undermine mental health, and create a cycle of dependence Understanding this mechanism is essential for effective prevention, early intervention, and evidence-based strategies in treatment. Thank you very much. Thanks for listening.
All right. Thank you very much there, Dr. Dauda Suleiman. He's gone far and beyond even expectations, even far and above what we thought would be his limit. Thank you very much, dear Dr. Dauda Suleiman. He is a consultant psychiatrist and head of clinical services at the Federal Neuropsychiatric Hospital, Uduegba in Kwara State. It's a great pleasure to have you speak with us for that quite long time. That's an extensive one. Then we appreciate you, too, Dr. Suleiman. Quickly, we have for those that may want to contribute or ask questions, this is the time to switch over to the speakers for now. But first, let's appreciate all our compatriots that are joining us via our Facebook page, that's at NDLE01, and those also listening in through our YouTube channel, that's at NDLE TV on YouTube. We appreciate all of you. And right here on X Space, we'd like to appreciate Dr. Wahab Abdullahi. Dr. Wahab Abdullahi is also a consultant psychiatrist, but at the Ahmadu Bello University Teaching Hospital, Zaria. Thank you very much, Dr. Abdullahi. We've also seen one of our Dr. Abdullahi joins us on the handle of Excel Mental Health Foundation. Thank you, Dr. Abdullahi, for. I would appreciate those lovely books. We're digesting them. Everyone had gotten their copies. Thank you very much, Dr. Abdullahi. And we also have Dr. James Komolafe. Dr. James Komolafe is also a senior member of this platform. Thank you, Dr. James Komolafe. We have Genetic Hetzma. Thank you, Genetic Hetzma. Funsho Jimo, a regular. Dr. Jonah Kolo. Dr. Jonah Kolo is a senior officer of the agency. In fact, the coordinator of our alternative development unit. Thank you, Dr. Kolo. We also have Papa himself. Papa himself, I believe, is a medical doctor on the platform. Sadatu Hamangari, thank you, Sadatu. We have Cyril Shima, thank you. Peter Oyebola, thank you. Yes, I have long lost her, but she's back. Perpetua Nandi Mane, Perpetua, it's quite pleasant and interesting to see you this afternoon. I believe you are doing well. Thank you very much, Perpetua, for popping in today. It's a great pleasure to see you. All right, we also have Alessandra Okoro. Thank you very much, Alessandra. Alessandra also works in this field, sensitization on drug abuse through his own foundation. That's Alessandra and Sonia Foundation, I believe. Thank you very much. Okay, somebody is Dr. Abdullahi. If you can hear me, I'm just getting a message from Dr. Asiya and Amubu now, because I gave you out by saying I got copies of your book, and Dr. Asiya is asking, I didn't get my own copy of the book you just mentioned. I believe we have to link you up with Dr. Abdullahi there. Dr. Abdullahi sent them in this week. I think we got them this week. One for the chairman, one for me, and one for my colleague, Francis. Thank you very much, Dr. Asiya Adamubi. I'm sure Dr. Abdullahi will find a way to reach you. Thank you. All right. Still acknowledging our compatriots on the platform. I believe definitely what it means is Dr. Asiya Adamubi is on this plan. I mean, she can hear us now, so meaning, but I'm not sure I saw her. I've not seen her, but definitely for her to. Okay, maybe she's listening in through on Facebook or. Okay, she's acknowledging that the speaker was quiet for us. Thank you very much, Dr. Asiya Adamubi is probably listening in on Facebook on our YouTube channel, because I'm not seeing her on X here. All right, apart from Alessandra Okoro, we have Wole Ganus. Okay, Wole Ganus, that's alias Eleribu. Okay, that's interesting. Femi Aino, thank you. Edna Kasley, thank you. Suleiman Olamide, thank you. Emi Abu, thank you. Gabos, thank you. Euphemia, thank you. Winnie, thank you. Awin Fleck, that's at Awin Yax. Thank you. Victoria Ochechi, these are all regulars on the platform. Suleiman Surajo, thank you. Jerry Miracle, thank you. Black, Isaiah Shimogo, thank you. Ibrahim Baba, thank you. Bamidele Miriam, and we also have Dr. Kehinde Oderide. Dr. Oderide was with us last week as a guest. Thank you very much, Dr. Kehinde Oderide there. We also have, I've also seen another senior member and a regular on the platform, that's Mohammed Waziri. Thank you very much, Mohammed Waziri. We have also, I've also seen Buhari Yakubu. Thank you. Joe Ololo, Jude Oshe, Femi Ladiran, Prince Isaac, Dennis Nna, Avata, that's Dr. Dimeji. Thank you. Genius, thank you. International Black King, thank you. Yaron Daddy, thank you. Suleiman, thank you. Well, let's take a pause now so that we can have people that want to speak um, let's have some other insights and contributions. Thank you very much. Okay, let's start with Dr. James. Dr. James, please go ahead. After Dr. James, then we have Dr. Abdullah. Dr. James, please go ahead.
Thank you so very much, Dr. Abdullahi, for today. I hope you can
No,
hear
that's
me.
Dr. Suleiman, Dauda Suleiman. Dr. Abdullah is just speaking after you. Our guest speaker is Dr. Suleiman, Dauda Suleiman.
Okay, Dr. Suleiman, thank you so very much. Dr. Hasiabi is my friend, so if you are giving her a book, please remember me too in your kingdom.
What's happening here? You people are setting trap for Dr. Abdullah here.
Thank you so very much for a wonderful and very inciting delivery. The question I would like to ask is, you have mentioned the various comorbid issues and variables that coexist in a patient. My mind is just asking, how well are we practicing that in Nigeria, where a patient comes for pharmacological interventions, and from there, we'll be able to access every other expert. I know in Western clients, you can have just what we call common case here. And you have 5 different experts in the field arena of the subject matter coming to play. So here, how practicable, sir? Because I have not seen that synergy working so well that you say, okay, I've handled you on this area, we refer to this or that, or we having them present. Is this Japa syndrome that is affecting us, or we're just not arriving at that level of synergy in Nigeria? Thank you, Doctor.
All right, Dr. Suleiman, you can go ahead and speak to Dr. Komalafe's question now.
Thank you very much. Thank you, Dr. Komalafe. We talk about the access to other experts is the management of substance use with comorbidity. Actually, we have some problem with other experts, especially in this Nigeria, because of what you have already observed as Japa syndrome. However, we have some centers. For example, in Nigeria, we have some neuropsychiatric hospitals in Nigeria. Presently, we have 10 federal neuropsychiatric hospitals in Nigeria. I think many of them are better equipped than our teaching hospitals and general hospitals in this moment of comorbidity, especially with psychological or social problem. For example, in our center where practice, we have psychologists, we have clinical psychologists, we have social workers, then we have psychiatrists that we work together. So we do patients together during the brand. And sometimes you observe that people have major psychological problem and they may not need medication. You send them to the psychiatrist and they will take over. And though you also be seeing them. However, I practiced for a long time in teaching hospitals, like 2 teaching hospitals as a consultant. this synergy was not there, because I think maybe the department is not well funded by the government, and we have few experts in other fields that are leaving the country every now and then. So that may be the problem. But in psychiatric hospitals, I think government is trying to get some experts. Though even there, the number is still very limited, but it's better than in some of these general and teaching hospitals where none exist, basically. So that is what I say about that particular question. Thank you very much.
All right, thank you very much there, Dr. Suleiman. I believe that is taken care of. Let's have Dr. Wahab Abdullah now. Dr. Abdullah, please, let's have your contribution.
Good afternoon, Mr. Femi, and good afternoon to all our listeners. Thank you very much, Chief Suleiman. I just want to use the opportunity to thank Mr. Femi and his team and the agency and everybody that has been here with us for the support and encouragement. So with regards to copies of the book for Dr. Asia and Dr. Kobolafe, I think I will have to send it through Mr. Femi. For any other person that is interested in getting the book, you can reach out. We can deliver the book to you anywhere within the country and even outside the country. So all you need to do is to get in touch with us, and we will be able to deliver, whether individual copies or bulk purchases. So I thank every one of you for the support and encouragement. And we look forward to your feedbacks so that we can improve on the subsequent editions. Thank you very much.
All right, thank you very much there. That's Dr. Abdullah there responding to the rush for his book by Dr. James. Dr. James and Dr. Asia Damubiu, I believe both of them are pleased now. So rest assured, as soon as I get copies, they will get to you ASAP. All right, let's take the next contribution. Okay, yeah, now my Perpetua. I don't know when last I saw you, Perpetua, but I'm so excited when I saw you on the space today. And I'm sorry, I knew I didn't see you for a long time, but I should have checked on you, especially since I know you are my handle. All right, let's have Perpetua's intervention or contribution. Perpetua, please go ahead.
Good evening, Mr. Femi, Dr. Femi. It's been a long time. Good evening, everyone. Am I audible enough?
Very loud and clear, Perpetua. We miss your voice.
Thank you, sir. Thank you for all you do for the agency and your team. Thank you, Dr. Dauda Suleiman, for this teaching. Please, I have two in one question. And the first one is, what are the most effective withdrawal management and the relapse prevention approaches across these substances? You made mention of substances like alcohol, opioids, cannabis, stimulants, and nicotine. So how the most effective withdrawal management and the relapse prevention approaches across these substances. Then the second one is, how should pharmacology therapies be integrated with behavioral and psychosocial interventions to support their recovery and functional outcomes? So the whole picture of this question is what intervention is these pharmacology therapies, what are they bringing into the behavioral aspect and the psychosocial intervention to support the brain recovery and also functional outcomes? Because I know when they come to take their medications, they'll be given some medications or some intervention of some advice, things that they need to do in order not to go back to where they are coming from or how they relapse. Because in the situation whereby they are trying to recover or not going back to the same thing that they have been feeding on or the same circle that they have found themselves, how will these the pharmacologists, the people that will
help them recover fully? How will they support their brain recovery and functional outcomes? I believe I will clear enough.
Okay, thank you, very Perpetua. Let's have Dr. Suleiman now. Dr. Suleiman, please, if
Okay. Thank you very much, Perpetua, for the question. I think the first question talks about the effective withdrawal method, effective way to treat withdrawal method in individual with substance use disorder. I think the first thing that we consider is what the type of substance the individual is using, or the type of medication you determine the method or the substance that you use for the withdrawal stage. You know that the normal withdrawal state is also what we know as detoxification state. For example, somebody who is using alcohol, for instance, now, you want to use graded reduction of benzodiazepine in such an individual. Also, you take care of the memory problem by use of adding thiamine to the regimen. Then you take care of the calories, and because your main aim there is to prevent development of chronic encephalopathy syndrome, then to prevent seizure, that's delirium tremens in the individual. So that's around the type of medication that we are going to use. The treatment will be different from somebody who is presenting with opioid withdrawal symptoms. If it's opioid, for instance, the best way is to manage symptomatically. For example, if somebody is withdrawing from opioid, most time they will present with this open tap syndrome, that is, they will be losing excessive use of body fluid. So we try as much as possible to replace those fluids being lost by the body. Then you now take care of other symptoms of the patient is presenting with, if it's agitation or any other things. You use appropriate medication to take care of them. That's what we do. For somebody who are presenting with opioid overdose or toxicity, that's when we talk about the use of naloxone or naltrexone. I'm fairly sure that naltrexone is available in the country. I'm not sure of naloxone for now. So if it's not available, we also manage symptomatically. You look at the symptoms by which they present. So, but what the most important thing there is that you look at the substances the individual is using. That will determine the type of medication that you use in the management of their withdrawal symptoms. And your aim then is that you want to reduce the discomfort to the patient as much as possible and to prevent development of complication in the patient. So that's how you handle that one. Then the second question, you asked about the implementation or the integration of pharmacotherapy to behavioral and psychological treatment in relapse prevention. And relapse in people using substance, if you look at the examination of addiction, you say it's chronic relapsing brain disease. So relapse sometimes is still part of the problem. So, but you realize your treatment and you look at what is causing relapse in each of the individual. So by individual them and know the source of the problem, sometimes it might be psychological. So that means your main plan will be physical, the psychological approach to the management. If it's social problem that's causing the relapse, maybe you want to address some of the social problems, maybe unemployment, living environment, and some other things. You want to look at it. But sometimes the relapse may be as a result of comorbid mental illness. So that in that case, you treat the primary mental illness. So when you take care of the primary mental illness, that will also take care of the relapse, because we said during the course of the training that sometimes patients that are having comorbidity will be using those substances as a form of self-medication to relieve the symptoms in them. And while they are using this medication, they are causing more danger or more problem to themselves. So if you are able to identify any psychiatric symptoms in the individual, you also take care of that to reduce the chance of relapse in the individual. we also look at the issue of medication-assisted therapy. Ideally, it's not supposed to be something that will be for life, because somebody is using one form of opioid, for instance, you want to replace it and you stop one, you now use methadone to treat the individual. So your aim is that you want to gradually reduce the one that you are using, that is methadone, over time, before eventually you stop the medication. So if you don't rush it, if the rate of stoppage is not too rapid, the individual may adjust properly, and the rate of relapse may also be low. Another thing is that there are some medication for craving, all this anti-craving, that can use to reduce craving, because most problem, the big problem after discharge is craving for those substances after discharge. Because initially when they are undergoing rehabilitation, they are in protected environment. But after discharge, when they get they are no longer under your supervision, and the environment is there, those substances are readily available, and some of them you want to be tempted, craving for this substance. So some people have advocated for the use of anti-craving to reduce some of these symptoms. But also, you have to be very careful in the sense that you are not replacing one addiction with another substance. So that's but by and large, you are going to individualize your treatment format. You consider each patient as being unique, and it's not that maybe one cap fits all in this instance. Thank you very much. I hope I've addressed your question.
I believe so. Okay, thank you very much, Dr. Suleiman. Let's quickly take the next contribution from Joe Ololo. Joe Ololo, please go ahead. Okay. Apesha, are you saying something?
No, I'm thanking him. Thank you so much. It's well explanatory. Thank you very much. Thank you.
All right, let's have Joe Ololo now.
All right, thank you. I am Joe Ololo. So, all right. So, my question will tend towards pharmacogenetics now, because I love what doctor said the last time, that you cannot treat people like one cap fits everybody. So, in this instance now, I want to know, how do genetic factors influence an individual's response to medications for addiction and mental health? And breaking that down now, I would love to explain that genetic variations can affect how medications are broken down in the body. So I have seen instances where some people will take in evil substance in the first place, and it will work differently in their bodies. And I believe that is because of their genetic structure or something. So now, if we are now introducing to them medications that can help them out of usage of substance or abuse of substance, now this gene too will come up. The genetic structure of the person can be by it. So now, is there any personalized program now that doctor can recommend, or is there any research ongoing for personalized risk into the study of genetic structures of people who abuse substance and how this can help in their treatment?
All right, thank you very much. Dr. Suleiman, please go ahead.
Okay, thank you very much, Mr. Ololo, for the question. Like I said, there are so many experimental form of treatment that is ongoing now, and just like you said, the role of genetics in the manifestation and even treatment of substance use disorder cannot be overemphasized. And like you said, you know that some individuals, because of the presence of some genes in their body, it prevent them from using some particular substance. For example, I think there are some people in Asia that they have some mutation of some particular genes that each time they try any quantity of alcohol, they react badly to it, serious reaction to it. And because of that, they don't go back to use of alcohol again, and the prevalence and incidence of alcohol use among them is very low. So, but as we speak now, The problem or the issue of genetic analysis in Nigeria is still very low, if not non-existent. Apart from DNA for paternity issue and some other tests, I don't think we'll be using genetics to analyze type of medication that individual can use that will be very suitable for that particular issue. Though there are some proposal, there are some experiment that are reading from other clients, but I'm not aware of any in Nigeria presently. They don't use genetic analysis to see the kind of medication that will be useful to that particular individual in the management of substance use disorder. But definitely, genetics play a vital role in the development of addiction. And if people can look into that, I think it will be a very good way of tackling or handling the problem of substance use disorder in the society. Thank you very much, sir.
All right. Thank you very much there, Dr. Suleiman. I believe Mr. Joe is cool with that. Let's quickly take some questions from our DM. Let's take this one from Mayawa. Mayawa is asking, how can early intervention and pharmacotherapy reverse drug-induced brain damage? I don't know if I missed that in the presentation, but I just need to understand this. Thank you very much, Dr. Suleiman, for your brilliant presentation. All right, thank you, Maya Wade. Let's over to you, Dr. Suleiman, please.
Okay, so the brain is one of the organs in the body that don't heal normally. When there is damage to any part of the brain, you cannot grow a new brain cell. It grows by neurosis. That is like a scar we develop in the brain. And as at present now, there is nothing that you can use to reverse that permanent brain structure damage already in the brain now. So that's why prevention is very, very important. The early detection is also very important, because if you detect early, before you have irreversible damage to the brain, there are things that you can do. But by the time the patient is presenting with permanent damage to the brain, you cannot reverse that particular state again. So maybe you cannot just be managing palliative management and some other form of management, but to reverse the brain, no, it's not possible. But if you catch the individual early, there are some things that you can do to help in the installation of some of these lost brain activities. People have talked about some medication like neurofite, all those things that will help you to revitalize the brain. But that's when you don't have permanent brain damage then. But by the time you have permanent brain damage, it will be by glycosis and it cannot be reversed again. I hope I'm able to address your questions.
All right, thank you very much. I think as you were landing on that, Thomas dropped in, which is like a follow-up, or he probably just needs an emphasis on that. Did I just hear Dr. Suleiman right that brains already damaged by drug use, especially loss of memory, can never be recovered? I just need this clarified. All right, thank you, Dr. Suleiman. You may wish to clarify that for her.
Okay, we're talking about structural damage. It's come from brain and memory impairment, which is not a result of brain damage. In my course of presentation, I said that some drugs can have direct toxic effect on the brain. It's all these ELANs, there is all these substances that they sniff. Because they have lipophilic property, they can dissolve some aspect of the brain. Also, somebody who presents with alcoholic problem that develop Wernicke-Korsakoff syndrome may also have some damage to the brain. You cannot be reversed again. But if somebody presents with memory problem, memory impairment, maybe as well of, it might be psychological. So when you take care of the problem, there is something we call pseudodementia in people with depression. Depression can present as somebody who is having dementia or memory impairment. So, but if we take care of that psychological problem, the memory will come back. For somebody who has had physical damage to the brain, that cannot be reversed. So that's what I said when I answered that question. Thank you very much.
All right, thank you very much. It's becoming more interesting. I have these ones from, I'll ask them one after the other. They are from Ojonide. Ojonide is asking, I would like to ask the speaker, how do synthetic drugs, for instance, synthetic cannabinoids, kush, bath salts, create more severe neurotoxic effects than natural substances? I think it's trying to create a line between the effect of synthetic drugs on the brain and the as against the natural substances. Did you get the question, Dr. Suleiman? Okay, please go ahead.
Okay. Then I believe that all these synthetic cannabinoid medications are drugs. They are more dangerous than naturally occurring cannabis. In the sense that even don't know the actual content or ingredient of some of these substances, because they are like cocktail of so many substances, and some of them they have toxic effect on the brain, and that's why some have more devastating effects than naturally occurring substance, cannabis in the brain. So, and that has been the observation. Even at present now, some of the regular UDT that are used to detect presence of cannabis in the urine may not even pick some of these synthetic substance. That will show that they are not actually cannabis, but they are just combination of so many substances. And if eventually they contain all these solvents and other lipophilic substances that I said that they have ability of affecting the brain directly, they have as neurotoxicity. So they present with more danger or more complication than naturally occurring cannabis. So I believe that's the reason why they are more dangerous than naturally occurring cannabis. Thank you.
All right, thank you. There is a second question from the same person. I would like to also know the relationship between substance-induced psychosis and neurotransmitter dysregulation.
Okay.
Dr. Suleiman, you got that?
Yeah. The substance-induced psychosis, just like we said, when we are talking about the link between mental illness and substance use disorder, when we talk about substance-induced psychosis, that what we are saying essentially is that this individual is presenting with psychosis is as a result of substance the individual is abusing, that's making the individual to present with this psychosis. That is, the psychosis is as a result of use of psychoactive substance. But if we are talking about the neurotransmitter dysregulation, we are talking about we are the level of molecular level or genetic level of pharmacology of the addiction. It's not something that you know, that you see physically. We are just trying to see how some symptoms develop. For example, if you have substance that produces so much dopamine in the brain, for example, you say that some substance like cocaine can lead to release of so many dopamine in the brain. However, the brain will now sense that this thing is excessive. So the brain will now reduce the number of receptors that will be available so that excess dopamine will not have to act on. So that means the brain is trying to dysregulate the neurotransmitter that's being released in the limbic system or in the brain. So that's what that is just trying to explain. So we are talking about at the molecular or genetic level, where the substance-induced psychosis is just saying that the psychosis this individual is presenting with is as a result of substance the person is using. So that is just the difference between the two terminology.
All right, thank you very much. I believe we're getting satisfied there. Before we go back to take more questions from our DM, I believe we just have barely 9 minutes left. Let's quickly take hear from Sati. Sati, please go ahead. Your contribution or question. Unmute yourself, Sati. Okay, if Sati is not ready, let me take the next question from DM. Okay, let's take this one from Jude. Jude is appreciating Dr. Suleiman for his presentation. Blah blah blah. Thank you very much, Jude. Yeah. Okay, and then is reacting to some of the statements by Dr. Suleiman and saying that we often see a lot of, with all that Dr. Suleiman has presented on the dangers, especially of this synthetic cannabis like Loud and Colorado, yet we see the high consumption of these substances by our celebrities and entertainers who claim that these substances give them energy to go on and then inspiration to do their work. Why have they not really shown signs of some of the dangers pointed out by Dr. Suleiman, if indeed these things are real? Okay, or they are real, Jude, but then let's allow Dr. Suleiman to respond to that. Dr. Suleiman, please go ahead.
I was thinking the question direct to NLA. But now, you want to know whether those things are real or not. They are real, and you come to hospitals, you see people that are using all these substances coming down with psychosis. And even we have some celebrities, they break down with mental illness as a result of substance use, but they may not popularize or publicize it when they have problem. That's the first question. Secondly, we say that everybody that has substance use disorder must have used substance at one point or the other. However, not everybody that is using substance that will develop substance use disorder. So they may be part of the few people, among the few people that have not developed that one. Another thing that what you see on the screen might not be what they are doing in their room or in their privacy. They may just do those ones to say their albums or to say themselves. Meanwhile, they may not be actively using those substances, which because you know that the quantity and duration of substance is also predisposed or determine whether the user will come down with mental illness as well of using of this substance or not. So those are the factors that I can talk about for now. That may be responsible. Is either they just do as make believe, or they are not yet developed the mental illness, or they are even be on treatment, maybe or they are even on treatment, but you are not aware of such. But substances, where these synthetic cannabinoids are very dangerous to the brain, and they can cause substance-induced psychosis and other mental illness in them. Thank you very much.
All right. Thank you very much. I believe this is a convenient point for us today to draw the curtain. We'd like to appreciate our guest speaker today, Dr. Dauda Suleiman. Dr. Dauda Suleiman is a consultant psychiatrist and head of Clinical Services Federal Neuropsychiatric Hospital, Bodo-Egba in Kwara State. Dr. Suleiman has given indeed a very good account of himself today. Well experienced, crisscrossing different tertiary institutions, that's medical tertiary institutions across the country. That shows quite a lot of stuff there. Thank you very much, Dr. Suleiman, for the great insights, for the contributions today. I would like to appreciate everyone that has been a part of this, especially The woman that can see us, but we're not seeing her, that's Dr. Asiya Adamubu. Thank you very much, Dr. Asiya Adamubu. We'd like to also appreciate Dr. Abdul Wahab Abdullah. Dr. Abdul Wahab Abdullah is a consultant psychiatrist at the Ahmadu Bello University Teaching Hospital, Zaria. We also have our own Dr. James Komolafe right here in Abuja here. Thank you very much, Dr. James Komolafe. We appreciate the lady I've been looking for, especially back, Perpetua Nnamdi Emmanuel. Thank you very much, Perpetua, for popping in today. My greetings to your kids, your family. Thank you very much for being a part of the conversation today. We have to appreciate everyone, all of us. I can't just continue to mention names, and quite a lot of people who are joining us from across the globe, whether on your YouTube channel, on our Facebook page, or right here on X Space. I also like to appreciate my colleagues that have worked with me behind the scene here: Neta, Francis, Dele, Mahmoud, Victor, Kumbi. Who else is there? Okay. Okay, and the rest of you guys, please just forgive me if I can't remember to mention your name at this moment. And I appreciate all of you. Thank you for a job well done. Again, we'd like to say thank God it's Friday, but then please don't forget that you also have to keep your guard. Let's stay vigilant. Let's be careful. Let's avoid things that will do that may give us momentary pleasure. But then the consequences, we may have to live with the scars of such. So let's avoid those things, and let's stay safe. Until we come your way again next week, I like to say bye from this side, and I leave you in the hands of Mahmoud. For weekend. Bye.
Thank you very much, sir, Mr. Fem Babafemi, the NDLA Director of Media and Advocacy, for guiding us through today's program. For more information about NDLA, our listeners can visit our website www.ndla.gov.ng. Our social media platforms remain at NDLA Nigeria